And a very good evening. So you must be aware about this initiative Pocket Clinics that is designed specifically for MBBS final year students and also the MBBS graduate uh, who are just out there to practice, right? So here the idea is to orient you how will you approach a case, right? How will the patient present to you? How will you get a case in the exam hall? How will you take history? How will you examine? How will you go down towards the differentials? And how will you manage the patient overall, right? So without further ado, let's start, right? So think of is my video clear to you all? Because I feel there's some blurring around the edges. Okay, it's fine now, right? Okay, so let's start with the approach to diarrhea in children. So let's imagine a scenario. You are working in the emergency department and an 11-month-old in the lap of the mother rushes to you. Can you notice how this child is very cranky, very irritable, soiled with loose stools? The mother says it's been 3 days and he is having high volume of loose stools. How you're going to approach to this case, right? You can clearly see that mother is distressed. The baby is very cranky. The very first thing that you have to do is not to panic, right? You don't have to panic. You have to think very systematically, very strategically, and manage this case. With that, let's start with the initial clinical approach. So, whenever you are in an emergency, before you even touch the patient, your assessment should start, right? The assessment of a child with diarrhea specifically will begin before even you touch the patient. So we have this triangle, the pediatric assessment triangle, in which very rapidly in the very first 60 minutes, you have to assess the child. Firstly, you have to take care of the appearance, whether the child is looking alert, whether the child is irritable, whether the child is lethargic. Look at the tone or the muscle activity of the child, right? If there is hypotonia, the activity is poor, and the consolability. If the child is consolable or not, the cry is consolable or not, right? Second would be the work of breathing. Abnormal breathing pattern is going to tell you a lot of things. Specifically in this case, you can feel that the child is breathing very rapidly. It could be pneumonia. But remember, in a case scenario like diarrheas, what can happen? There could be this compensation as a result of metabolic acidosis. The child could be breathing really fast, right? So don't mistake that as pneumonia. It could be actually metabolic acidosis. So look for the work of breathing. Is it a deep rapid breathing? Could be a small like breathing. Are there any abnormal sounds, wheeze, grunting, retractions, nasal flaring? And lastly but not the least, circulation. Look at the skin color. Like skin color tells a lot, right? You can actually see a child who is very pale looking, mottled skin is there. This child needs immediate attention. This child is in shock, would require resuscitation. On the other hand, if a child is looking very pink to you, on touching, if you feel the child is warm, there's no need to worry about circulation per se for now, right? So these three things, remember: PAT, pediatric assessment triangle. You have to look at the appearance, the skin color, circulation to the skin, the work of breathing, right? Okay, so now after this initial assessment, let's start with the ABC approach, right? Airway, breathing, circulation. So the number one priority for you in this scenario, when you are working in this emergency, would be to prioritize shock, right? If there is any shock like situation, you have to immediately curb that, right? We need to pick up any life threatening scenario and manage that then and there. Thereafter, we can go ahead in assessment of diarrhea, evaluation, dehydration assessment, correction. But the number one priority in this case should be identifying shock. So go towards ABC approach, assess the airway, is it clear or is it compromised, breathing, the rate and depth, and circulation. For circulation, we check the capillary refill time, right? You press along the bony edges, right? In smaller children, we use sternum. You can use the tip of the finger also. If the capillary refill time is more than 3 seconds, that is indicative of shock, right? And if the child looks very lethargic to you with all these signs, very low feeble pulse, cold hands, prolonged CRT, lethargic, all of these signs point towards shock. So if there is a suspicion of shock, you have to manage shock first, right? Before going towards classifying dehydration and management, firstly focus on shock, right? So this should be your first thing. Prioritize identifying shock. After that, you move towards your diarrhea assessment. And whenever you are looking for diarrhea, what is the key in the management? The key in the management is correcting your dehydration, right? So before correcting the dehydration, you should know the danger signs. If any of these danger signs is there, you need to immediately admit this child and give rigorous IV fluids, right? So remember these WHO danger signs. In if any of these danger sign is there, urgent admission is required. These are the red flags, right? First is if the child is unable to drink or breastfeed. Second, if the child is vigorously vomiting everything out. If the child has seizures, if the child is lethargic or unconscious. These are the four major danger signs that you need to notice. Apart from that, obviously, if the child is looking very cyanotic to you, if the child has severe respiratory distress, all of these again would be danger signs. If the child has not passed urine, there is oliguria, again a danger sign, right? Broadly, think about these four. Apart from these, take a note. It could be oliguria or anuria, that means decrease in the urine output, right? Second, if the child has severe respiratory distress, signs of severe respiratory distress. The child is appearing cyanotic to you. The saturation is low. All of these would be danger sign, right? After these danger signs comes the proper history taking. So whenever you are encountering a child with loose stools, why history taking is important? Because history taking will help you, number one, to firstly tell the severity. Second, it would also help you towards delineating the etiology, right? So, for example, if there is a clear-cut history that this child had some fast food from outside, so that could be a source of gastroenteritis, right? On the other hand, if the history tells that it is a chronic picture going in the background, that you won't think of acute gastroenteritis or infectious pathology, right? You will think of chronic conditions, malnutrition, and everything, right? My professor used to say that your history should be such that you come to 80 to 90% of the diagnosis. 80 to 90% of the diagnosis is clear. Investigations take up the rest 10%, right? So when you are taking about history taking in diarrhea, think about 4Ds. Diarrhea is D, right? So think about 4Ds. The first D, take a history about the diarrhea. Firstly, you are going to ask about the frequency. How many loose stools did the child pass in a day and night both. Then the consistency, whether this is liquidy, watery, whether this is semi-solid, whether the child is actually passing thick stools, whether the child has fatty stools, trattoria, whether this stool is floating or not, right? Consistency basically, whether this stool has blood or mucus in it, that could point towards dysentery or intussusception, and the duration, whether this is an acute diarrhea, whether this is a chronic diarrhea. Second D, first D was taking the history about diarrhea, and I told you what you are going to ask. You are going to ask about the frequency, consistency, whether there is presence of blood or mucus in there, and the duration. Second is dehydration status. Some things come in the examination part, but some things you can actually ask the caregiver. What are you going to ask? Firstly, ask about the fluid intake, whether this child is able to take fluids or not, whether this child is continuing the breastfeeding or not. Ask about the urine output, whether the child is passing adequate urine or not, whether there is oliguria or not. Oliguria, if there is a danger sign, is a major red flag, right? Ask about the weight loss, whether obviously the parents are not weighing the baby every day. You generally ask whether this child has, you seem that the child is losing weight, whether the clothes are now ill fitting, right? And also ask about the specific symptoms, that whether the child is excessively thirsty or lethargic. This is about dehydration assessment, right? These are the things that history tells you. Examination part of the dehydration will cover, but these are the pointers in history. Then comes establishing the diagnosis. That means I'm going to ask about etiology. I want to probe what is the cause of this situation, what are the cause of the diarrhea. So I'm going to ask about the recent travel, if there is any recent travel history, any contact with the sick people, any dietary changes, any medication history, so that I can come to a conclusion what could be the cause of this loose stools. And lastly, danger signs. Remember the four danger signs. If the child is not able to breastfeed, not able to drink, if the child is lethargic, unconscious, if there are convulsions, if the child is vomiting out everything, right? So all of the danger signs come under this fourth D. So remember, these four D's will be covered in your history taking. So in this situation, after the ABC approach and the triage, you are going to do this 4Ds. Firstly, ask the mother about diarrhea, frequency, consistency, is there any blood or mucus plug, or if there is any sort of the duration about that. Then come about the dehydration, the diagnosis part, and the danger signs, right? 4Ds. Moving towards analyzing the diarrhea, I told you you are going to ask these four things: duration, frequency, consistency, volume, and also if there is any mucus or blood in it. Why this is important? Obviously, if there is large volume stools, that point towards secretory diarrheas. If there are small frequent stools, it point towards colitis. If there is blood in stool, this is dysentery. This favors the bacterial etiology, not the viral etiology, right? So it's very critical that you ask about these detailed stool history, right? Moving to assessing the hydration cues. What are the questions you're going to ask? You ask the mother these five critical questions. First, if the child drinking normally, is the child continuing the breastfeed? How many times the child has passed the urine? Is the child unusually sleepy? Is the child thirsty? Right? So I'm going to ask all of these five critical questions. The answer should be either yes or no by the mother. Right? If the mother seems confused, take it as a danger sign only. Right? If the mother is not sure, take the worst case scenario in this case. And remember, if the mother tells you that the child is not passing urine, or the urine is just once or twice in 24 hours, this is oliguria, reduced urine output. That is a massive red flag, and you need to urgently admit this child, right? So, moving to the red flags, I told you this: red flags, persistent vomiting, abdominal distension, all of these things could be there. Now, moving to the physical examination part, how you're going to physically examine. I know when you encounter a long case or a short case, you go from head to toe. But in a scenario like acute diarrheas, when the child presents to you in the OPD or in the emergency scenario, then this examination has to be very, very precise, right? So, what are the examination points? Remember, whenever you encounter a pediatric patient with you, always the very first thing is do wait. Whenever I get a call that there's a patient in emergency and we need a pediatric consult, the very first thing I ask the nursing staff there is that please take the weight and the vitals of the child, so that once I reach, these basic things are done. Why do we need weight? We need this weight because in pediatrics, all the calculations are on the basis of this weight. Unlike adults, here in pediatrics, we do a lot of maths. We give the dosages on the basis of weight. Also, the fluids that I am going to give, would require weight, right? So whether you are prescribing ORS, IV fluids, or medication, you need the weight of the child. So always start with the weight, right? Always start with the weight. Then you go towards dehydration assessment. And how do we assess the dehydration? Look at this, how we are going to go towards that. Remember the mnemonic gets. G is for the general condition, E is for the eyes, T is for the thirst, and S is for the skin pinch. Firstly, the general condition. If the child is well looking and alert, this is no dehydration. If the eyes look normal, no dehydration. If the child is drinking water normally, what is this? You offer the water to the child and ask the child to drink. If the child is drinking very normally himself, this is no dehydration. And when you do skin pinch, if the fold returns immediately back, there is no tenting of the skin, immediate recoil is there, this is no dehydration, right? So no dehydration means the child does not have any degree of dehydration, just losses are there, you need to replace those losses. No dehydration has started as of now, right? So a well and alert child with normal looking eyes who is drinking normally and the skin pinch goes back instantly, this is no dehydration. Then comes some dehydration. What will happen in some dehydration? Now the child will become very restless. So general conditioner will be very restless, irritable, the child will be cranky, the scenario that we discussed in the start. If you look at the eyes of the child, eyes will look sunken. If you give water or ORS to this child will be very thirsty, will be drinking eagerly, and the skin pinch hair returns slowly. There is slight tented, but usually within 2 seconds it comes back. And lastly comes the severe dehydration. What happens in the severe dehydration? Now the degree of dehydration is very severe. The child would be either lethargic and unconscious, the eyes would be very sunken. If you offer water to this child, either the child won't be able to drink or drink very little, very poorly. And if you look at the skin pinch, it goes very slowly. There is persistent tenting, more than 2 seconds it takes to come back, right? So this is the WHO hydration assessment. Remember the mnemonic gets, general conditions, eyes, thirst, and skin pinch, right? So let's revise together. No dehydration child, that means no dehydration is there. So how would be the general status? The child would be alert, eyes would look normal, thirst would be normal, skin pinch, you will have an instant recoil. Moving towards some dehydration, here the child will be restless, child would be irritable, eyes will look sunken, this child would be very thirsty, right? Thirst is increased. This child will very eagerly drink. And there is slow recoil, but it usually comes back within 2 seconds, right? There is just slight tenting of the skin. Then comes severe dehydration, danger, danger. Here the child is lethargic or comatose, unconscious. The eyes are very sunken. If you offer water to this child, the child won't be able to drink water, right? So unable to drink. And the recoil here is very slow recoil, right? Persistent tenting would be there. So how are you going to manage now? So if there is no dehydration, we go for plan A, where we just replace the losses. If the child has some dehydration, we go for plan B, where we correct the dehydration and also take care of losses. And then we have severe dehydration again, where we go for plan C. Here also the principle is correction of dehydration and maintain the ongoing losses, balance the ongoing losses. The problem comes in the choice of fluid, what fluid you are going to give. Remember, always giving orally is the best. Giving orally is the best. If the child can drink orally, no need to give IV, right? So in no dehydration, I know the thirst is normal, so I can give oral. In some dehydration, again the child is actually drinking very eagerly, so again I can give oral. But in severe dehydration, the child is lethargic, comatose, is unable to drink or very poorly drinking, so here I have to give IV, right? So when we talk about oral rehydration, we have ORS, oral rehydration solution, And for IV, the choice is ringer lactate, right? So one by one, let's discuss this management. I told you that the management is just classification driven. You apply this GETS, general assessment, eyes, thirst, skin. If there is no dehydration, go for plan A. If some dehydration, plan B. If a severe dehydration, plan C, right? No investigation per se are required in cases of acute watery diarrhea. You don't need to go for basic investigations like CBC, CRP, or stool cultures. On the basis of just this assessment, you are going to treat. No antibiotic has to be given because most of the pediatric diarrheas are actually viral diarrheas, right? So you straight away move towards dehydration management. Let's start with plan A, that is no dehydration. So here we give ORS. What is the dose? Usually, as a broad rule, 10 ml per kg per loose stool, right? But broadly, if the child is less than 2 years of age, you give 50 to 100 ml per loose stool, and after that 100 to 200 ml, or as much as the child wants to drink uh, per loose stool, right? And remember, this period, continue breastfeeding and offer small amounts of the age appropriate food. You don't need to stop the diet of the child, right? Whatever the child was taking before the loose stools, you continue with that. So this is plan A, no dehydration, just replacing the losses, nothing else, right? Moving to plan B, some dehydration. Now I know there is dehydration. There is some degree of dehydration. So I need to treat the dehydration first. But how I will do that? I will use oral rehydration over here, ORS. So how do we correct this dehydration? We correct this over 4 hours. We give 75 ml per kg over 4 hours. So if the child is 10 kgs, I am going to give 750 ml of ORS and ask the mother that she should offer the 750 ml over the next 4 hours. And along with that, whatever losses are there, you have to continuously replace also. So for example, in these 4 hours, the child passed stools 4 times. So 4 times, that means 4 into 10 again. Sorry, 10 ml per kg I told you. So 40 ml extra the child has to be offered. 40 ml extra the child has to be offered. Right? So per loose stool you have to continue this. Right? So continue replacing ongoing stool losses. If the child vomits taking ORS, then you pause for 5 to 10 minutes and then restart ORS slowly using small frequent sips. And after the 4-hour period, you again reassess the child to check the level of dehydration. If the child is still in some dehydration, you continue this dehydration therapy. And if the child's dehydration is gone, you can continue with just replacing the ongoing losses. Moving to plan C, that is severe dehydration. Here we have to give rapidly IV fluid. We choose ringer lactate. If ringer lactate is not available or contraindicated in some case, then the alternative would be normal saline. We give 100 ml per kg total. How do we give this 100 ml per kg? If the child is smaller child, that means less than 1 year of child, then you give this firstly 30 ml per kg over 1 hour, followed by 70 ml per kg over the next 5 hours. If the child is a bigger child, more than 1 year, then you give this 30 ml per kg over 30 minutes, followed by 70 ml per kg over the next 2.5 hours. Remember, whenever you are giving this rapid IV fluid, you have to continuously reassess this child because we don't want overhydration. Overhydration is deadly, right? So continue monitoring the hydration status. Whenever you feel that there is overhydration signs, that means if you feel that liver is getting palpable, you notice increase in the heart rate, respiratory rate, that moment stop IV fluid and switch to ORS as soon as the child is able to accept that. Right? So this is about the management protocol. And remember, apart from giving oral rehydration solution and IV fluids, apart from hydration, you have to prescribe zinc for 14 days for each and every child with loose stools. What is the dose? This was recently asked in your FMG exam. If the infant is less than 6 months, 10 mg per kg. After that, 20 mg daily. Right? So this is the dose, 10 mg daily for less than 6 months, and after that 20 mg daily. What is the benefit of giving this zinc? It decreases the episode, decreases the severity of the current episode, decreases the duration of the current episode, and also decreases the chances of recurrence of diarrheas further in future. If the mother tells you that doctor, now the child doesn't have loose stools, do I still need to continue zinc for 14 days? The answer is yes, right? If the loose stools has gone, you still need to continue zinc for 14 days. A 14 days course has to be completed, because as I told you, it further decreases the chances of recurrence of such episodes, right? Apart from that, another important viva question that the examiner throws at you is when you are going to give antibiotics in cases of diarrhea. So I told you most of the pediatric diarrheas are viral. You don't need to give antibiotics. You just need to take care of the dehydration component and supplement for zinc. When you are going to give antibiotics, there's a certain specific situation. Firstly, if there is blood in stools, you are suspecting Shigella dysentery. Obviously, it's bacterial, you need to give antibiotic. If there are rice water stools, you know this is cholera. So cholera, again bacterial, you need to give antibiotic. If you are suspecting enteric fever, again, if it is an immunocompromised patient, if it is a severely malnourished child, then again you need to give antibiotics, right? Otherwise, general rule, most of the pediatric diarrheas are viral. Antibiotics have no role, so do not prescribe them. They do not shorten the viral illness, and in fact can introduce uh, resistance, right? So it's better to avoid antibiotics in cases of pediatric diarrheas. And remember, notoriously known, some of the quacks, they prescribe this antidiarrheal drugs like loperamide. Strictly avoid these in children because of the chances of ileus, right? Ileus is very common because of this abuse of antidiarrheal drugs. With that, we zinc up to any age. If you have diarrhea, you can also take zinc, right? Actually, you should take zinc. All of us should take zinc. Prakhar, for systemic pediatrics, I believe either way is done, right? Most of the people, what they do is they study medicine and then go towards applying it towards pediatric concepts. The pediatric topics that are separated, they read that only, right? Because an overlap is there. On the other hand, some people do differently. They read pediatrics thoroughly and apply that concept to the medicine. Whatever you want to go for, if you're interested in pediatrics, then definitely read from the pediatrics textbook. Otherwise, medicine is also fine. So that's all about diarrheas. So let's recap what we did, right? So coming back to the scenario, I hope now you're very confident in dealing with such a patient. So an 11-month-old came to you, right? So now I'm giving you a scenario. You are, tell me what you're going to do next, right? So this 11-month-old come to you. 11-month-old child comes to you with the loose stools. What you are going to do? Firstly, assess, right? Before even touch, you assess. For 60 seconds, you do the pediatric assessment triangle. Look at the appearance of the child, the circulation, and you look for the work of breathing. So I tell you that this child is looking very irritable, right? You can see the child is looking very irritable, right? If you look at the skin is looking pink only. If you look at the work of breathing, the work of breathing is fine. What you are going to do, the second step, ABC, airway, breathing, circulation, right? So airway is fine, breathing is fine, circulation is fine, pink and mom. Now you go towards history taking about the diarrhea. So the mother tells you that loose stools are for 2 days, right? The child is irritable from 1 day. The frequency of these stools are 10 times per day. There is no blood or mucus, right? And there is introduction of some new food, right? So clear cut etiology is there, introduction of new food that has led to this diarrhea situation. And what is the protocol over here? How you're going to examine now? Gets general appearance is irritable. If you look at the eyes, mother says the eyes look sunken, the child is very thirsty, and if you look at the skin pinch goes back slowly. So what is this? This is some dehydration. Yes, this is some dehydration. So I told you this child is an 11-month old. The weight is 10 kg. How much ORS you are going to give? 10 into 75, that is 750 ml over the next 4 hours. And apart from that, as the child is less than 2 years, so general thumb rule, 50 to 100 ml of ORS per loose stools you offer to this child, right? And apart from that, obviously, we are going to give zinc. This child is 11-month old, so 20 mg zinc every day for the next 14 days the child has to take, right? So this is all about diarrhea, approaching diarrheas in children. If any doubt is there, please tell me. I'll be more than happy to cover that. And if not, we can end the session. Okay, so I hope this slide helps you to get a vision, right? So whenever you are in an emergency like situation, firstly do the basics, pediatric assessment triangle, the ABC approach, then go towards looking for history that I told you, 4Ds, right? And then you examine the child. Examination, I told you, the mnemonic gets, general appearance, eyes, thirst, skin, right? And depending upon this examination, you to go towards dehydration correction, plan A, B, C. Along with that, add zinc, and remember the indications of antibiotics, suspicion of dysentery, cholera. If it is a severely malnourished child, an immunodeficiency is suspected, right? All of these would point towards a bacterial cause and you would need antibiotics, right? So thank you. I tried to make this presentation for the first time using AI, and I gave my material to the AI and asked to make a depictive picture, right? And let me know if the style works. Otherwise, I'm more comfortable writing, right? So next time I believe we can do partially both of the things. I hope that helps. All the best for your exams, and I hope from now on you're going to manage a child with diarrhea